Good morning. Welcome to our Thursday presentations. Please, if you have your phone, please can you mute your phone, and so that at least we can have the presentation without interruption. Today, I would like to introduce our own Dr. Lee-Anne Godinho. She's a South African physician in internal medicine with a specialist expertise in critical care, geriatric medicine, and pulmonary health. She earned her MBCHB from University of Pretoria, completed her MMed internal medicine at University of Witwatersrand in 2017, and is a fellow of College of Physicians of South Africa. During COVID-19 pandemic, Dr. Godinho was appointed as chair of the clinical committee, performance committee, provide leadership in clinical governance and patient safety. And after 2024, she continued to represent critical care on the same committee, ensure high standards in multidisciplinary care. He also established and leads a Mediclinic Midstream antimicrobial stewardship program, developed hospital-wide protocols for responsible antibiotic use and infection control. As a founder and host of the Sanocare Bread of Hope podcast, Dr. Godinho brings her academic knowledge and frontline experience into accessible, inspiring conversation. Her ability to blend rigorously science with compassionate storytelling make her a trusted voice for both healthcare professionals and the public. Beyond medicine, Dr. Godinho finds relaxation and balance in painting and baking, nurturing the same creativity and patience that she brings into her clinical work. With her academic credentials, clinical leadership, and human warmth, Dr. Godinho embodied a new generation of physicians who not only treat disease, but also inspire hope, knowledge, and resiliency. Thank you, Lee-Anne.
Thank you, Emmanuel, for that long bio. Okay. So, as I said before, I like presenting topics that are kind of apply to all practices and all different doctors. So today I'm talking about insomnia in the elderly or in the older person. So, as I've already alluded to, it's a very, very common complaint, and I don't think there's a doctor anywhere that hasn't heard this complaint before. And the insomnia, really, you need to understand that it coexists with a lot of comorbidities, medical, neurological, and psychiatric disorders. And it's often precipitated by stress, by medications, by substance abuse, and can be perpetuated by poor sleep habits that people develop in response to the insomnia. So the diagnosis really includes three main components. There's this persistent sleep difficulty, despite the fact that the person has adequate opportunity to sleep, and there is an associated daytime dysfunction. So when we talk about acute insomnia, it's usually a few days, but can last up to a few weeks. And it's usually with an acute physical, psychological, psychosocial, or interpersonal stressor. So it's the physical would be, for example, acute injury or acute illness. And then the other psychological, psychosocial are the big ones: divorce, end of a relationship, death, moving, and a job loss, etc. So if acute insomnia is not handled properly or taken seriously, what can happen is that the person develops poor sleep habits, and then this insomnia becomes a chronic insomnia. So chronic insomnia or insomnia disorder, by definition, is at least 3 times a week for at least 3 months. But as we all know, patients often come and say, well, I haven't been able to sleep for years. So just to go into a little bit more about how, what it is, it's a perceived dissatisfaction by the patient in the quality or the duration of their sleep. So they either have difficulty initiating sleep, so difficulty falling asleep, or difficulty staying asleep, therefore maintaining sleep, or they wake up way earlier than what they would like to. And this is, as I said, is always despite adequate opportunity. So this is not somebody who's working long hours, who is not getting enough sleep. So most adults will take about 10 to 20 minutes to fall asleep. And patients with insomnia generally take more than 30 minutes to fall asleep. They can spend more than 30 minutes awake during the night. And they definitely awake more than 30 minutes earlier than the desired time if they're experiencing the early wake up. So how does it compromise their daytime function? Obviously, fatigue. Your concentration and attention can be impaired, and the person may not be able to function or perform well in their job. They have daytime sleepiness. This can also lead to irritability and mood disturbance. They generally just have this lack of motivation and energy. And then they can have more errors and accidents because of the lack of focus. And there can be an ongoing worry about sleep, even during the day. So here I've just wanted to demonstrate how the vicious cycle of insomnia starts. So there is a lack of sleep, and then the person may be laying in the bed and start worrying about daytime fatigue. They start worrying about what they're going to do at work. How am I going to give my presentation because I've been awake all night? And then inability to fall asleep or initiate sleep rapidly because this is kind of ruminating in their head. And the more time they actually spend awake in bed, the more they worry and the more they don't sleep. So previously, insomnia was actually classified into primary insomnia and secondary insomnia. So primary was, when there was no cause to be found, or organic cause that could be found. And secondary was when there was an associated comorbid condition that was diagnosed. However, we don't really use this nomenclature anymore because the direct causality and association is not always determinable. So what is the chicken, what is the egg, and what is an association versus a cause? It's not always clear. So just to go through some of the comorbidities, psychiatric is the kind of one that we all know. Depression, anxiety, bipolar mood disorder, post-traumatic stress disorder, eating disorders, substance abuse disorders, and psychotic disorders can all lead to insomnia. And then just along this is a long list, which I'm just going to go through quickly. But basically, any system, when you have illness elsewhere, it can actually keep you awake. So at the top, we've got pulmonary, so COPD. I think we've spoken in other presentations before, most of the conditions, lung conditions that give you dyspnea will actually worsen at night because of the pulmonary vasculature. And if they're short of breath at night, they're not going to sleep. So dyspnea can actually keep you awake. And then obstruction of the airway, so allergic rhinitis or nasal polyps. Musculoskeletal is an important one because these people have aches and pains. They can't lie in one position for a long time, and they actually can be woken up by the pain. Then cardiovascular, nocturnal angina, heart failure will give you paroxysmal nocturnal dyspnea if it's left-sided, and ischemic heart disease, they can all keep you awake at night. And endocrinological hyperthyroidism or thyrotoxicosis can cause anxiety and insomnia. And a very important one in the more elderly population is genitourinary. So there might be nocturia, urine incontinence, and lower urinary tract symptoms, especially males with benign prostatic hyperplasia, incomplete voiding of the bladder, and then urinary retention, all can keep them awake. Gynecological, menopause, hot flashes is quite a common one, and then pregnancy. And gastrointestinal, so gastrointestinal reflux is going to be worse in the supine position, and can keep somebody awake. And then anything that can cause severe pruritus, like extensive eczema or liver disease, can also keep you awake. The neurological conditions are important, especially the kind of neurodegenerative conditions like dementia, Alzheimer's, Parkinson's. They are all associated with insomnia. And then painful peripheral neuropathies or radiculopathies can also cause it. Cerebral strokes and brainstem strokes, brain tumors, traumatic brain injury, because sleep starts in the brain. Those can affect it. And then sleep disordered breathing is also a very important one, like obstructive sleep apnea, obesity, hyperventilation syndrome. Then restless leg syndrome, periodic limb movement disorder, and you do get circadian rhythm sleep disorders, which I will kind of just touch on, but I'm not going to go into details. And then medications is quite a frequent one. Those seen as stimulants, a lot of the antidepressants, corticosteroids. I mean, it's part of your circadian rhythm. Your cortisol will peak in the morning. So if we start giving patients corticosteroids to take at night, it will keep them awake. And then pseudoephedrine, that's, if you're having congestion. And then the obvious ones, caffeine, nicotine does as well, alcohol as well. Some people think they sleep better when they have a bit of alcohol, but it can actually also impair your sleep. And then diuretics, I'm going to give old people especially diuretics to take before bed, because they will be spending the whole night getting up. And then phenytoin. So what happens to sleep, specifically in the elderly? Old people do have lighter, shorter, and more fragmented sleep. And this is because their sleep architecture changes. Their slow wave deep sleep is reduced, and they have more of the N1, N2 light sleep. And this basically, and the REM latency, so their time to the REM sleep is much longer, which means they get REM sleep much later in the night. And obviously, if they're waking up, they may not get it at all. And then this results in multiple nocturnal awakenings and fragmented sleep. You also get an age-related decline in melatonin. Melatonin is the hormone that is secreted when it is dark at night, which also helps with initiation of sleep. And they get a circadian rhythm shift. So older adults are sleepier earlier in the evening, and then they wake up early in the morning or feel more awake early in the morning. There's also reduced sleep drive because of less adenosine buildup in the brain during the day. So this is just a graph to show the young adult versus the elderly. And the blue one is the young adult, and the dotted red is the elderly. So you can see that the old person is not getting to the deep sleep. And their REM sleep, which is here, is much later in the night compared to the young person, and it's much less. So, and then kind of logic tells you also, as you get older, more frequently will the patients have these comorbidities that I've mentioned. They're often on a lot of different medications, so polypharmacy is quite common. And there is a change in their, especially if retired, or perhaps institutionalized in in an old age home or something like that. There's boredom and social isolation. So they might be daytime napping, and they're not as active physically as they were before, because of frailty, and this all will result in poorer sleep. And they might be staying indoors all day long, meaning they don't have much exposure to natural light, which means the normal circadian cues are not there. And then because they've got nothing else to think about necessarily, they may become quite preoccupied with the fear of having no sleep and catastrophizing what the next day might look like. So the consequences in older people will be increased risk of accidents, for example, if they're still driving, or just accidents in the home. They can have fatigue, decreased memory and concentration, which they may already have a problem with, and then impaired performance on psychomotor tests, and then important increased risk of falls. I've done a presentation before on falls, and there's significantly increases their morbidity and mortality. Can cause cognitive decline and like I say, increased mortality. So just as a side, that's not for all people in specific, but it has been shown that in younger people, when they don't sleep, their ghrelin levels will increase, resulting in increased hunger, appetite, and can actually, if the sleep duration is less than 6 hours, it is associated with increased risk of insulin resistance and type 2 diabetes. So how do you evaluate a patient with insomnia? A lot of us, this might be a very important problem for the patient, but I want to challenge everybody and say that we should perhaps make it a bigger problem to us ourselves as doctor. We should become more concerned, and you need to be a type of detective to figure it out. So when you evaluate them, the history is quite important. When you decide on how you're going to manage them, you need to know what kind of sleep or insomnia symptom are they having. Are they having sleep onset difficulty? And that's really the patient that says, I can't fall asleep at night. I just lay there for hours. And then a follow-up question to this could be, do your legs bother you when you're sitting or lying down? If this is the case, you might want to check their iron studies. If needed, you can give them iron supplementation. And if you think this is restless legs, you might need other medications to treat it. You want to know, is this person a night owl, or they just like awake and not tired until very late at night, and then struggle to get up in the morning? And this is when there is an issue with the circadian rhythm and sleep-wake. There's delayed sleep-wake phase disorder. Sleep maintenance difficulty is usually the patient that says, I wake up 100 times a night, and then I can't keep my eyes open in the day. That's the daytime somnolence. And they usually complain that they can't fall back to sleep easily, or if they do, they just keep on waking up. And this is where I want to ask questions like, is there snoring? And you can use, I will speak about it in a moment, the stop time questionnaire. You can screen, is this a person at high risk for sleep apnea? And if so, we're going to do a polysomnogram. And you really want to know why, it seems like a detailed interrogation, but that's what it needs to be to get to the bottom of it. Why are you awake? Why do you keep on waking up? The patient might not tell you that they are getting up to go to the loo. They have nocturia. So you need to ask the detail. Early morning awakening. This is usually the patient that will say, I wake up early, and then I can't get back to sleep. We used to call this, I don't know if I haven't read the term recently, but a terminal insomnia. This is the person who's waking up at 2, 3 in the morning. And if there is a low mood, low motivation, anhedonia, and all of that, then you could be dealing with somebody who has depression. And if they are just struggling to stay awake in the early evening and then waking up very early, they may have the circadian rhythm disorder called advanced sleep-wake phase disorder. So decreased quantity of sleep, yes, if they're waking up a lot, it will reduce the quantity. But you also get people who just don't go to bed. They are working late into the night and or exercising late and things like that. And in these patients, you really want to emphasize the lifestyle changes. So if somebody says, well, I don't think 6 hours sleep is healthy, so I try to get more than 6 hours, but it doesn't matter what I do, I can't sleep more than 6 hours. If they're not tired in the day, this is normal. This is normal for that particular person. So this is quite small on the screen, but this is just an image that gives you an idea of what is the recommended hours of sleep, what could be considered normal or appropriate, and then what is really not recommended, going from 0 to 3 months on the left all the way to the older adult 65 plus on the right. So focusing on the 65 plus, 7 to 8 hours is still what's recommended, but 5 to 6 hours might still be appropriate for that person. The older you get, the less sleep is needed. So you may need in your evaluation to actually give them a sheet to complete a 1 to 2 week sleep diary. So what's included in this is, what is their bedtime? When do they eat? Do they drink alcohol? When do they drink it? What medication do they take? When are they having cups of coffee, caffeine? When do they exercise? And then when are they sleeping at night? And when are they waking up? And you also want to know about naps. So after you've consulted with the patient, maybe you don't know what's going on still, you don't have a clear picture, then you can give them this to take home. And then there's a lot of other scales that can be used, which again, you could consider giving some of this to your patient to take home and then sending to you once they've completed it. So just to go through, then the Stop Bang questionnaire is for obstructive sleep apnea. All of these are available online, and they are sort of validated scores that you can calculate to tell you what if sleep apnea is likely. The Epworth Sleepiness Scale. You have the GAD-7, which is also very kind of easy questionnaire that the patient can complete, and then again scoring tells you about anxiety or generalized anxiety. The Patient Health Questionnaire 9 is also including depression that you can pick up. And then you have scoring systems for trying to pick up sleep disturbance if the person actually has a sleep disturbance. So this is a Pittsburgh Sleep Quality Index and Sleep Problems Questionnaire. So you might want to, it might be helpful to interview the partner, because it's always the patient's perceived sleep, how they perceive their own sleep. People can tell you, I take 3 hours to fall asleep, and the wife will be like, no, he puts his head on a pillow, then he starts snoring. And that's when he's tired in the morning. So, it might be helpful. And then you want to know what are the other contributors. So again, I'm just emphasizing, you want to ask, why? Do you have pain? Do you have shortness of breath? what is it? Are you having so many hot flashes at night that you keep on waking up? And then you want to kind of identify this anxiety and poor sleep habits that the patient might have. So are they stressing about the lack of sleep? Do they have unrealistic expectations of sleep? This is quite a common one, especially in older people. So if you can imagine an elderly lady who doesn't have much company during the day, if she's sitting in her chair having small little naps throughout the day because there's nothing else to do, she's listening to the radio maybe, and in between that, she's sipping 1,000 cups of tea, and then she goes to bed at 7:30, 8 o'clock because there's nothing much else happening. That's not realistic to expect to go to sleep at that time because it's too early. She's had a lot of rest and sleep that she's maybe not even taking into account during the day. And then you get obsessive clock watching in the bed, you get people that tell you that every time I lie there and I feel like when I look again, another hour has gone past. Or when I look again, it feels like 3 hours, but there's only a half an hour's gone past, and I do that the whole night. Um, you know, those people are obsessively watching the clock, and then they develop maladaptive responses. They stay in bed and they spend a lot of time in bed awake, and it actually leads to being awake more. So it's kind of like a learned cue or a learned behavior that the brain, starts. Bed is no longer a cue for sleep. So it's not like, the brain gets used to lying in bed awake, and that only perpetuates the situation. And then environmental disturbances, people have partners that snore and whatever, and you also have people that sleep with 10 dogs on their bed and then don't get enough sleep. So physical examination is always very important because you're going to pick up heart failure or arthritis or whatever on your physical examination. Laboratory testing, there's really not a specific blood test that you need to be doing, but you want to do general checks on these people. They look at their general overall health. So you do routine screening bloods, and you may want to include thyroid function, electrolytes, iron studies, and so on. The polysomnogram is what I mentioned. That is a sleep study, and it's going to pick up sleep disordered breathing and things like that. Actigraphy is a type of wrist-worn device that objectively measures sleep onset and wake times. So a lot of people have commercially available watches. Most of the smart watches type thing are able to tell you about your sleep, but this is not really recommended because none of those things have been validated. The recommendation, as far as I read, is that you can't use that to make your clinical decisions on that, but it might help to get an idea. And then your further investigations, they're guided by your clinical examination and then to remember to do the general things on the patient that need to be done, like an ECG. And then you may take it further with a lung function or echo, and a referral to appropriate specialists to properly investigate and manage underlying conditions. So how do you manage it? The sad thing is that there is no real quick fix. I think doctors and patients alike would prefer it if there was one little magic tablet that we could take and then sleep, have a good night's sleep. But this is unfortunately not the case. And when you manage the sleep disturbance, you can't ignore the underlying conditions, as I said, the medical conditions. You want to really go into detail about what medication, when are they taking it, and you want to, as part of your management, look at the polypharmacy and cut down some of the medication. This is especially important in older people, as I've said in a previous presentation, that elderly individuals often go to different doctors or visit the doctor on multiple occasions, and they have many ailments and minor complaints, and often more and more tablets are added for these minor complaints, and there starts to be elements of polypharmacy and interaction of medication. So you want to go through the list and see what is actually going to give them benefit. And in all patients, you want to encourage good sleep hygiene. So what is this? How can I, if the patient wants to know, how can I get better sleep? These are some of the pointers you would give them. They should try and have the same, so blurry, but I'll read it out. Same bedtime and wake time every day. They should have, if they're having coffee or caffeine, tea, they should try and do this before lunchtime in the morning. They should try and expose themselves to natural light early in the day. They should try and go out in the garden, basically. Avoid eating close to the bedtime. Avoid heavy meals and late night snacking at night. And avoid alcohol also in the late afternoon, evening, bedtime, as it can contribute to the problem. Avoid smoking in the evenings. Keep the bedroom dark, cool, and quiet. And if they're exercising is good. It can aid sleep, but you should actually be doing it if you're suffering from insomnia, 4 to 6 hours before bedtime, not close to the bedtime, because it can keep you awake. And then this is more easily said than done. Solve your problems before bedtime. So you try and settle your anxiety, or something that you think when you get in bed, you're going to start worrying, oh, I should have put that thing there to remember to take it to work tomorrow. Maybe do those things before you get in bed. And then do not check the time at night, and avoid kind of screen time before bed. So you're going to not want to look at smartphones, clocks, alarm clocks, and watches. Keep them out of sight, so you actually don't have the risk of becoming preoccupied. And avoid naps, long naps. So you don't want to have the person have any long naps longer than 30 minutes. Especially after 2 p.m. So if they can, a short nap early in the day, if they need to have one, and going to bed only when sleepy. So a lot of people, like I've said already, they make the mistake of going to bed because they feel they should be sleeping at a specific time, and then they are not tired at all when they get in bed. And the more they lay there, the more they're not tired. And to try and avoid that. So how do we deal with acute insomnia? Acute insomnia, that's the one that I said, there's usually a kind of an identifiable cause. The patient will tell you, well, it started after the death of my friend or something like that. And many a time, you don't need pharmacotherapy. You can just reassure the patient that it is normal during this time to have insomnia. And you can offer them psychological support and reassure them that most cases, this is going to be a temporary thing, that it's not going to be forever. But if you do think that the person is going to benefit from medications, you use them temporarily and you follow them up, in a fairly short period to see if you can start stopping and weaning the medication. So, in the management of chronic insomnia, the important thing to remember is that good sleep hygiene is not generally considered sufficient. It is something they should learn to do, but it's not going to solve all the problems. The real first-line therapy, and there's a lot of evidence to support this, is cognitive behavioral therapy. And what is this? It is psychotherapy. It's a multi-component approach, and it kind of addresses those thoughts and behaviors that perpetuate the situation. So it identifies, helps you identify unhelpful thoughts, like, if you're laying there saying but if I'm not asleep by 10 o'clock, there's no way I'm going to do that meeting tomorrow. I'm never going to survive it. That's not a helpful thought. And to challenge the thought and change your thinking to, even if I go to sleep a little later, chances are I'll make it through the meeting because I've done it before. And then it also addresses behaviors. So sometimes this involves sleep restriction, and that's where you really only go to bed when you're tired. And what can be helpful is to look at the sleep diary and see, okay, this person is more or less sleeping 6 hours, and then they are waking up at 6 a.m. So that they're going to bed at 9. So in that person, you will tell them, you're not going to bed at 9, go to bed at 12, at midnight. And it's reinforcing those cues to the brain that when you go to bed, you go to sleep. And you want to kind of do this over and over and over again until the brain, knows that this is what needs to happen. And some people don't want to do this. They become extremely anxious when you tell them they must go to bed, because how can, I remember one patient told me, how do you expect me to sleep if I'm not in bed? And it's the whole point. When you're in a bed not sleeping, it's not doing you any good. It's actually making the situation worse. So in those patients, you can do what is sleep compression. So you still want them to go to bed at midnight, but you kind of slowly do it. So it seems a lot better to them. So they say, okay, tomorrow you go to bed at 9:30 instead of 9. And then slowly, then 10 o'clock and so on. So the biggest problem here in South Africa is that we don't have a lot of trained professionals. There's not a lot of people you can refer to that really have experience in doing this. So it's problematic. It's really a problem for us, seeing as it's our first line treatment. But there are some kind of digital apps that can be used, but unfortunately, I've mentioned a few of them. They require like subscriptions, and it's not always free, and it doesn't always help as much as the face-to-face treatment sessions. So going on to the pharmacological management, you're going to take into consideration age. What is the main insomnia complaint? And then I'm referring to is it sleep onset, sleep maintenance, or what? And then you're obviously looking at the cost, and you're looking at the side effect profile, and you want to use the lowest. The principle is to use the lowest effective dose. This one, I'm starting off with it. Maybe I shouldn't, but it is in the world. It's one of the first ones that get mentioned. It's not available in South Africa, so I'm just briefly going to mention. It is a doxepin. It is at low dosages. It works as a potent H1 histamine antagonist, but at high doses, it works as a tricyclic antidepressant. So at low doses, it reduces the arousal and works well for sleep maintenance and is useful in the elderly at these low doses of 3 to 6 milligrams at night. Then prolonged released melatonin. This is the other names, circadian, cardiotef, and then there's a few others. It acts on the M1, M2 receptor in the suprachiasmatic nucleus and helps realign the sleep-wake cycle. So, as I said before, melatonin is your natural hormone to help you go to sleep. So the dose is usually 2 milligrams of the prolonged release. Circadian is a prolonged release, and it's you want them to advise them to take it 1 to 2 hours before bedtime, but sometimes benefit is only seen after 3 to 4 hours. It is very safe. That's really the most the nicest thing about it, is that it is very safe, minimal side effects, and you can't get addicted to it. It is quite expensive with it as the originator. It's 426 Rand, but there are some slightly cheaper generics available. The issue with it is that there's only a modest efficacy. So sometimes you need to combine it with something else. And the main side effects are headache and a slowed reaction time. And then elsewhere in the world, you get a melatonin receptor agonist, which we don't have yet. It's called Ramelteon, but it basically works the same as we have. And this is kind of the exciting one that's fairly new in South Africa, dual orexin antagonist, or DORAs. There's suvorexant, lemborexant, and daridorexant. So lemborexant is Dayvigo, that's available in South Africa. And the mechanism is that it blocks orexin in the hypothalamus, suppresses the awake drive, and promotes sleep. So it's important, or it helps, and it's effective in sleep onset and maintenance. You can start at 5 milligram and go up to 10 milligram. It is a good option in the elderly. It has a very low dependence rate, and the issue is that they can have some next day somnolence, and so maybe if they're still driving around, it might be a bit strong for them, but then that is why you would start at the lower dose. And then it is also quite expensive. It's the 10 milligram, after 5 milligram is 399, and the 10 milligram is above 500 Rand. So the Z drugs, we all know them. Zolpidem, Zolpiclone. We don't have the S-Zolpiclone in South Africa. There's just some of the names. Zolpidem is Zolnox, Zolpiclone. There's various ones, and the dosages are different. You do get a modified release of the Zolpidem, which is Zolnox MR 12.5. And the mechanism is that they potentiate GABA A receptor activity and increases the inhibitory GABA effect. So it's effective for sleep onset. It has a rapid action. There's many cheap generics of it available. So, it has been used safely for prolonged periods. There are studies that show that even after a year of using it nightly, somebody may not be, having an addiction to it. But the cons are really in the elderly. You get falls associated with fractures, cognitive impairment, and then complex sleep behaviors. This is sleep driving, sleep walking. I think if you are somebody who sees a lot of elderly patients, you will have seen somebody at some point where they got this medication and they went crazy at night, and it had the opposite effect. So in elderly, it's not contraindicated, but you want to try and kind of avoid it. It's not your first line. You will use lower dosages. The zolpidem, would go 5 milligram. Zolpiclone, would go 2.75 milligrams. And you want to really kind of limit the use. Benzodiazepines, they potentiate GABA A receptor activity, and you get widespread CNS depression. So it works really well for anxiety, and it's anxiolytic. It can work as a muscle relaxant. So a lot of patients find it helpful in falling asleep. But the problems are dependence, tolerance builds up. You can get withdrawal when it's stopped, falls, delirium, memory impairment, and it's associated with a high risk of hip fractures. So there's something called a Beer's criteria. It is a Dr. Beer that made a kind of list of medications and divided them into different categories, looking at the safety in older adults, and what medications might be inappropriate, which ones should be avoided, which ones should be used with caution, and then which ones need dose adjustment. And Beer's criteria indicates that benzodiazepines are to be avoided. It's leads to falls. But these examples of these are Dormanoct, Ativan, Alzam, Mormison. Trazodone, just to mention some of the other medications used in insomnia. It's antidepressant, and the dose is between 25 and 100 milligrams. It does help with sleep continuity, but it is off-label for insomnia. There's very weak insomnia weak. What happened? The presentation gone. Print anything. Can I try and share it again?
Yeah. Sorry, 1 minute, please.
Sorry.
Oh, it's almost there.
I can try and wing it.
Yeah.
But where is it? Browse.
Yeah.
My computer. Internet.
Yeah. Where to say the computer.
Okay, it's coming, I think.
Sorry.
Sorry about that. As I was saying, with trazodone, it's just loading. We were close to the end. Like a backwards doesn't let you go backwards. But it's slow. It's just slow.
Just 3 minutes, almost there.
Oh gosh, it's a glacial pace.
Just hang in there. The chair is almost there. The best still to come.
What happens if I click here?
Yeah, that's what time.
Okay, it's loading. There. Okay. So okay, weird. So the issue with trazodone is that it also causes orthostatic hypotension. So it's not ideal. It's not ideal for the elderly. It's not, but can be considered, if there is a underlying psychiatric disorder that you're also trying to treat, And then just concerning other, you can actually, so you're going to avoid it in the elderly unless you're treating depression with the insomnia. Okay. Then I just don't want to touch anything. Just to mention other antidepressants, mirtazapine, Miradep, tricyclic antidepressants, amitriptyline, commonly used. But the issue with them is that there really isn't much evidence that there is a therapeutic effect in insomnia, but people do use them for the sedating effect that they have. This might help with sleep, but you cannot use it for insomnia alone. You have to be potentially treating another psychiatric condition like depression as well. And then tricyclic antidepressants and the mirtazapine have quite severe side effects that are not ideal for elderly people. So I just quickly mentioned pregabalin, Lyrica, and gabapentin. There has been therapeutic effects that have been reported in patients with pain, restless leg, general anxiety, and epilepsy. So you could use it in these patients, but remember, there can be sedation, ataxia, dizziness, cognitive dysfunction, symptoms that you really don't want in an elderly patient. So you're going to we use it with caution because of the risk of falls. Antihistamines, so diphenhydramine, that's better sleep. And then hydroxyzine, Atarax used to be available in tablets, injectable and syrup. I think now it's only the injectable and syrup. The pros are they're very cheap and they are very sedating. The cons are really the strong anticholinergic effects that you're going to have, causing urinary retention, bad intolerance in the elderly. So in Beer's criteria, it's unsafe. You're not using it. Then antipsychotics, I wanted to talk about this because I know a lot of doctors use this. I do Google how to pronounce it. Quetiapine is how it says. And it is Seroquel, Dapaquel, Truvalin, Psychid, Kisara. The mechanism is H1,5-HTAA and dopamine 2 antagonism and results in sedation. So it has a sedative effect. It is useful when there's a comorbid psychiatric illness. The problem is that you can have extrapyramidal side effects, and there, as I will speak about this just now, there's an increased mortality in dementia, and it causes weight gain, can cause weight gain. So you actually don't want to use this, prolonged periods of time. I know in the hospital, we quite frequently use it, which is why I'm in elderly patients, and that's why I wanted to bring it up. But a 2025 retrospective cohort of 65-year-olds and older, starting on a low dose quetiapine for insomnia, found higher rates of mortality in dementia and falls compared to trazodone. So maybe that's not the correct thing. And if you're thinking I'm using it to prevent delirium in your in-hospital patients, a randomized double-blind placebo-controlled trial found no reduction in delirium with prophylactic quetiapine. And so also it's actually recommended against this. running out of time, but I'm just going to briefly mention that the take-home messages have been quite repetitive, but insomnia is very common and it coexists with lots of conditions. And your evaluation really needs a detailed, thorough history and physical examination. And management is always going to involve treatment of your coexisting illnesses. And sleep hygiene should form part of all management plans. And your first line treatment in the elderly is going to be, there's a typo there, cognitive behavioral therapy. You always need to be careful in the elderly when prescribing your medications, because you do not want your risks outweighing the benefits. Thank you.
Thank you, Lee-Anne. Thank you.
Not always good with the references, but there they are this time.
Just quick question. Should physician get anti-medication for sleeping, because most physicians really got insomnia because of the brains are too busy most of the time and they really struggle with the sleep?
All comes down to how they're functioning in the day. If they're functioning well in the day, no.
Okay, but I think I'm very happy with the highlight of the Seroquel, especially the quetiapine. And I think obviously, in the logic previously we have used it as a really for that it was supposed to be safer for elderly people, that's reduced risk of fall and everything. But I think probably the data that now the most controlled trial obviously say otherwise it's not. And I think it was medicine that was number one choice for geriatrician actually, that actually recommend using that actually. So I think it's something that we have to revisit it and perhaps change our own protocols in the hospital. Yes. Make sure that the patient get the appropriate therapy that will not cause it. The problem that with medicine, I learned one new quote in medicine, that medicine really is a science of uncertainty and the art of probabilities. And that really sum it all, that sometimes we really not certain about what you're doing because it's ongoing, because it's ongoing research. What you already know today might be wrong tomorrow. So the same thing, again, it's always, we try a probability to make sure that we cure the disease. So yeah, so thank you. And the fact that you actually have one day to prepare for presentation, it's amazing. Well done.
Thank you.
Michael, any question? The rheumatologist. We have today a rheumatologist joining us here, so you could imagine. So because rheumatologists are known for using a tricycling for pain control and sleeping. Michael, any comment on that? What do you use for a patient with the severe pain, joint deformities, and that they can't sleep despite being on multiple medication? Anything on the rheumatological side that you want to recommend your patients out there?
That sort of pain management, inflammatories. Yeah, they do use, you tend to use a bit of the tricyclics because it's got some anti-inflammatory effect as well.
There's the rheumatologist, really. Okay, and the tricyclic depressing and obviously maybe relaxing. And that's what's the problem. The noise coming from down. That's what they say about internet. That's why we had the problem. Thank you, guys. Any question online quickly? If we can take one question before we close. Okay, we'll look. All right. Thank you, guys. Have a nice day.